I'd like to welcome everyone to today's webinar, Compassionate Care Across Cultures and Languages, Finding Common Ground. I'm Lynn Osborne, Director of Business Development at the Schwartz Center for Compassionate Healthcare, and your moderator for today's session. The Schwartz Center for Compassionate Healthcare is a national leader in the movement to make compassion a vital element in every patient-caregiver interaction. Before we begin the formal presentation, let's go over a few details about the webinar. The Schwartz Center Compassion in Action webinar series is funded in part by a donation in memory of Julian and Eunice Cohen. Today's program will be 60 minutes. The first 40 minutes will be presentation, followed by a 15-minute question and answer session. Today's program is being recorded and will be available on the Schwartz Center website a week after the session. Please note that attendees are participating in listening-only mode, but can interact with the speakers and me by using the questions pane, which should be appearing on your screen. If you have questions, please just type them into the questions pane and send them to us, and we'll address as many of them as we can at the end of the presentation. We'll also be polling the audience during the session, and we hope you'll participate in this interactive measurement tool. As you exit the webinar, you'll receive an electronic survey that we ask you take a minute to complete so that we may capture your assessment of today's program. Your feedback is really important to us. And now it's my pleasure to introduce my colleague and our host for today's session. Dr. Beth Lown is an Associate Professor of Medicine at Harvard Medical School and the Medical Director of the Schwartz Center for Compassionate Healthcare. Welcome, Beth.
Thank you, Lynn. Good afternoon, everybody, and thank you for joining us for our 2016 webinar series on compassionate collaborative care, what we're calling the CCC. In January, during the first webinar of this series, I introduced this CCC model and its associated attributes and behaviors. I described some of the science of compassion and empathy and discussed why compassion is a source of reward and an antidote to burnout. The framework really explains some of the key values and skills that can help us offer compassionate and collaborative care to patients, families, colleagues, and coworkers, while also sustaining ourselves, our sense of happiness and meaning in our work. A full description of these qualities and skills is available on our website. Each month, we've been offering a webinar by experts on different aspects of the CCC, Compassionate Collaborative Care Model and Framework, and this month, we'll be focusing on providing care to patients whose cultures and languages are different from our own. People come with different beliefs, values, styles of communication. Some patients distrust the healthcare system or healthcare providers, attitudes which they may assert strongly or keep hidden. And language barriers then can add another layer of potential misunderstanding. So this webinar will present an overview of cross-cultural issues in healthcare and the role of empathy and compassion in addressing them. We'll also explore some case studies, reflect on effective approaches to providing compassionate, person-centered care to patients of all cultural backgrounds. So today we're honored to have as our speaker Dr. Alexander Green, who's currently a senior scientist at the Disparity Solutions Center at Mass General Hospital and teaches at Harvard Medical School. Following residency, he joined the faculty at Cornell, dividing his time between clinical teaching primary care at a community health center in Queens, New York, and development and implementation of a curriculum in cross-cultural medicine. Alex has authored articles on topics including cross-cultural education, culturally competent healthcare systems, and language barriers and interpreters, and he's been invited to present his work widely. Dr. Green's been involved in a number of research projects and national panels on racial, ethnic disparities in health and cultural competence, including most recently the Joint Commission's Hospitals, Language, and Culture Project. He also helped produce a documentary film, an education project called Worlds Apart, which was designed to teach health professionals to provide better care for patients across cultural divides, and this has been used by hundreds of organizations around the country, and I actually use it quite a bit. It's an excellent resource. His current research interests focus on clinician bias as a root cause of racial and ethnic disparities in healthcare, culturally competent quality improvement, and cross-cultural medical education. So welcome, Dr. Green. I'm going to turn the program over to you now.
Okay, well, thank you so much, Beth, for the opportunity to come and speak to the folks as part of this Schwartz Center webinar. It's a real pleasure to be here with you all virtually. We're going to be speaking a little bit about the topic of providing compassionate care across cultures, as Beth mentioned. And I've subtitled this Finding Common Ground because I think that really one of the big challenges for practitioners in their interactions with patients across cultures is trying to see how we are all similar rather than how different we are. And so that's what I'd like to try to focus on today in this presentation is, how can we reach across and find common ground with people who may seem very, very and, completely different from us in so many ways. And so that's really, I think, the job that we do as clinicians is we try to connect with people and provide compassionate care even when there are these potential barriers that make it challenging. So I'm going to give you a little overview here, which is that some brief background and some context on the topic as a whole. And then I'm going to describe an approach that we've used, we developed probably 18 years ago now and have, tweaked it and modified it and worked on it over time. We've actually kind of renamed it the person-centered approach to cross-cultural care. Because it really is about people, not just patients, and people as patients as people. And I'll provide throughout the course of doing this some mini vignettes, very short snippets of sort of case studies in how this sort of works or operates in clinical interactions, and I'll try to kind of give you some insights and tips on how to address those issues, and then we'll do the wrap up and the Q&A at the end. So this is a polling question, which I'm going to turn it over to Lynn to lead, to get some information from you all on how you think about this topic of cultural competency.
Excellent. So before we launch the actual poll, let's review the question that's appearing on this slide. The question reads, which aspect of cultural competence do you consider to be most important for effective patient care? We're going to ask you in a minute to select one of the following. Treating every patient with equal respect and dignity, culture, ethnicity, race, or social status. B, having a working knowledge of the important customs, values, and health beliefs for a wide range of cultural groups. Or C, having the skills to communicate well with any patient you see to explore how customs, values, and health beliefs may affect clinical care. So now that we've reviewed the potential responses, let's open the poll. Excellent. So getting these numbers in, you're going to vote A, B, or C. And I give a couple more seconds here. All right. Excellent. I think we can close the poll. And we can ask Alex what he thinks of the responses to his question. We've got 34% treating every patient with equal respect and dignity, 9% having a working knowledge of the important customs, and 56% having the skills. What do you think?
Okay. Interesting. So, I think that it's important to look at these not as necessarily an either or. I think all of these things have a role in cultural competency. To start, we'll just kind of take them one by one. Treating every patient with equal respect and dignity in the context of culture, race, ethnicity, that was supposed to say. Very, very important. There's no question that, especially when we're thinking about compassionate care, that treating people with equal respect and dignity in the context of culture and race and various characteristics that oftentimes make people feel not treated with respect and dignity, that is crucially important. What I always tell the students and others that I teach around this topic is that that gets you to a certain point. So you sort of have to have that that respect side of things to get further. but it doesn't get you far enough oftentimes to be able to really make a true connection. So for example, what if you don't know how to work with an interpreter effectively, or what if you don't ask the right questions that allow the patient to tell you more about their beliefs and their perspectives and that sort of thing? If you don't know some of the things to ask, you might really not get the information that you need to help understand the patient better. So with that in mind, what about the second one, B, having working knowledge of the important customs, values, and health beliefs for a wide range of cultural groups? So for many, many years, that was the crux of cultural competency. It was all about teaching about different groups and what the types of issues that would come up for different groups may be. And probably about 20 years ago, there was a movement that I was very involved in and my colleagues were very involved in to begin to push further than that, away, to some extent away from that, to say that knowledge is sometimes a tricky thing, because if we assume that we have knowledge of a cultural group, and so by knowing how that cultural group is likely to act or believe or think, that we're going to be able to provide better care for them, we oftentimes can jump into a kind of a stereotypic thinking process, or maybe a reductionist way of thinking about cultural competency. And so while knowledge is certainly important, and sometimes it's very important to at least have some knowledge so that you can then ask the right questions, I honestly believe that having the skills to communicate well with any patient in the context of their culture or their background in some way is probably the most important part. So it's interesting that the poll actually reflected that as well. But again, that's not to say that all of these issues are not important as well to some extent. So I'm going to go ahead and grab the controls here and move this on. Okay. Oops. Okay, so we've got this slide, which I think is very important because this talks about a kind of a model for thinking about cultural competency, both from the standpoint of the interaction in the healthcare system between the clinician or the provider and the patient, and how cultural competency is so important to that. And that's what I really focused for many, many years, a lot of my work and my teaching and my research on, is that individual interaction between a provider and a patient. But what we've learned more and more lately is that, in fact, that culturally competent individual provider-patient interaction exists within a system. And the systems also need to be culturally competent to make it possible for those effective interactions to take place. So again, just as an example, I can be a wonderfully culturally competent physician, and I may work in a system that simply does not have a robust interpreter service, and maybe not even access to interpreter telephones. And so how am I able to communicate and really provide culturally competent care with a patient that doesn't speak English or that doesn't speak the same language as I do if I can't actually connect and communicate with that person? So that would be just one very blatant example of how the systems have to be set up effectively. And there's many other ways that, where patients don't trust a healthcare system. They feel that they're not, treated with respect by the general system itself, as opposed to maybe the providers who they may or may not feel the same way about. So when we think about skills, as I was talking about, what are the skills that we need to be thinking about? So there are things like exploring patients' health beliefs and values, asking the right questions. And we'll talk a little bit about what some of the questions are that are helpful in getting into a patient's health beliefs and values. Communicating well with patients with low levels of health literacy. We have a tendency to assume that people are understanding our complex terminology and our jargon and things like that. And if we can just learn to speak a language that's simpler, that's clear, avoiding jargon, we'll get so much farther with most of our patients, even very well-educated people who may not understand these concepts and terms. And plus, across cultures, the terms don't oftentimes translate well. Working effectively with interpreters, we talked about already. Identifying mistrust and building trust, very, very important, because we can't assume that patients trust us. Discussing alternative medicine use, exploring different traditions and customs that could affect care. And I'll get into some of these with some examples as we go through little by little. So why is all this important? So just to, again, set some context for this. Back in the year 1999, when the census came out, we saw that the white population made up about 72% of the U.S. population as a whole. And all the rest, 28%, were considered racial and ethnic minority by the government classification: African American, Latino, Asian American, Native American. So that simple definition is then expanded when you look at the year 2030, the projections for just 14 years from now, where the white population will make up 60%, probably less than that, probably more like 58, 57%. And the minority population will make up over 40% of the total U.S. population. Some of the biggest growth will be in the Latino population and the Asian American population. Now, that's very clear, the amount of diversity and the growing diversity in this country. But even what may not be so clear, which is within that green segment representing white Americans, there's also a tremendous amount of diversity. There's socioeconomic diversity, there's linguistic diversity, there's religious diversity, there's sexual orientation or diversity. There's so much diversity just within that segment that it becomes very obvious that we are dealing with a population where we are all diverse. And so everything that we do really hinges on understanding people in the context of their cultural perspectives and beliefs. And in that way, it's not that different than patient-centered care, which is why we've sort of focused this as a patient-centered cross-cultural approach. In addition to that, 53 million U.S. residents speak a language other than English at home. That represents 20% of the U.S. population, and that's growing as well, up from 14% in the year 1990. About half of those folks have difficulty speaking English, so that's considered what we call limited English proficiency, LEP. So we see that there's cultural diversity, ethnic diversity, linguistic diversity, and then interestingly also tremendous amount of diversity around health literacy. 50% of the U.S. population is considered to have a low level of functional health literacy. And that's when you're referring to understanding basic medical terms about symptoms and illness, like the term biopsy, for example. If I throw out the term biopsy to a patient and say that, we need to get a biopsy and I will see you back in 2 weeks, what does that mean for the person? In my mind, it's very clear. Then we need to take a piece of tissue under a minor surgical procedure of a suspicious lesion, send it to a laboratory, have them slice and dice it, stain it, look at it under a microscope, and determine based on the cell structures and the staining patterns whether this particular lesion could be a cancer, could be an infection, could be a benign condition, and nothing to worry about. So this has tremendous implications for a patient's health and life. Again, a diagnosis of cancer perhaps versus a benign condition, and yet the term biopsy alone for most people actually doesn't necessarily have all those subtle implications. So health literacy is such an important piece to all this, and while patients who are immigrants and are from minority groups may have a higher percentage of low health literacy as a whole, the total number of patients that have low levels of health literacy in the U.S. Is made up mostly of the white population, interestingly. Again, talking about this breadth of diversity and how we think of diversity in the U.S., and many are elderly. Just moving on to slide 17. We have another polling question. I'm going to turn it to Lynn to run this one.
All right. So question number 2, or poll number 2, it should be coming up on your screen, and the question reads, what percentage of adult patients in the U.S. have limited functional health literacy? Please select one of the following. 10% for A, 25% B, 35% C, 50% D. And the polls are coming in. Again, the question is, what percentage of adult patients in the U.S. have limited functional health literacy? What percent of the population? Okay, I think we've got that numbers in. Close the poll, and here are the results. 2% say 10%, 13% of our respondents say 25%, 35% of our respondents say 35%, and 50% of our respondents say 50%. So, Alex, what do you think?
So actually, the answer is 50%. Half of adult individuals in the U.S., patients in the U.S., have what's considered limited functional health literacy. So again, it's an enormous challenge and a real crossover in terms of people that research health literacy and people that are interested in health equity and cross-cultural care. There's very much overlap between these things, and so there's arguments back and forth. And what's more important? Is it really culture? Is it health literacy? Is it socioeconomic status? They're all important. These are all important things to consider as we begin to try to provide the best possible care we can to patients of all backgrounds. So I put up this slide because I think it's representative to me of the notion of the complexity of the medical system. And so when we're talking about these challenges of language barriers and health literacy barriers and potential issues around culture and diversity in the U.S., all of that tremendous diversity of ways of thinking about health comes into almost a sort of a conflict or a crash with the tremendous complexity of our healthcare system, both in terms of the way that we provide care, so the high-tech procedures and the surgical preparations and everything that we do, the scanning, MRIs and tests and specialist care, as well as the complex systems that we have of paying for care, financing care, so Medicare and Medicaid and private insurance that also has Medicaid and Medicare embedded in it. So there's so many complexities, and it becomes very challenging for patients, especially those with low functional health literacy and those from different backgrounds who might not be familiar with our system, as to how to get the best possible care. Just as an example, I had a patient that I used to care for in New York City who was an 86-year-old Cuban woman who had I would say, a fairly low health literacy level, did not speak English. I spoke Spanish and speak Spanish and was able to communicate with her in Spanish, but not everyone on the healthcare team could. And she was actually having a problem with abdominal pain and was losing a tremendous amount of weight and wound up admitted to the hospital and had a CAT scan done, and the CAT scan showed a mass near her pancreas, and we were all concerned that this was potentially a pancreatic tumor, and she needed to have a better look at this to clarify exactly what was going on, and potentially take a biopsy, and so all of this stuff needed to be communicated to her, to her family, in ways that they could hopefully understand it. And then it came to the point where the recommendation from the gastroenterologist was that she needed an ERCP, endoscopic retrograde, I can't even say it, retrograde cholangiopancreatography. So now how do I take the complexity of that, and this complex procedure that we have to do, that we'd like to do, we think is important to do, and explain this to this woman and hopefully, get her to see that it really is in her best interest and it's important. And what is the reason why she would even go along with that? It's a scary sounding procedure. It's got a lot of potential downsides to it, pain, infection, bleeding, all the potential risks. So what gets this woman to decide that, yes, I will go ahead and do this, even if she doesn't fully buy into it or understand it or have a full conception of what it is? And it really, a lot of it comes down to trust. And trust is such an important thing in any interaction between a provider and a patient, but especially across cultures, and especially when there's a limited level of functional health literacy. But we don't have a high level of trust that we can count on among anyone in the U.S. necessarily, but especially among racial and ethnic minorities, where we see 35% and 36% of African Americans and Latinos, respectively, saying that they've been treated unfairly in studies, in polls, by the healthcare system based solely on their race or ethnicity. And the same polls have shown that 65% and 58%, respectively, say that they are afraid that in the future they will be treated unfairly by the healthcare system based solely on their race or ethnicity. So we can't assume trust. And that's why this becomes such a challenging thing when you want to do your best for patients, and yet we have to think about how are we going to build their trust first. Well, what does the data show? Do they have reason to mistrust us in the healthcare system? In fact, they do. If you look at the unequal treatment report from the Institute of Medicine that came out over 10 years ago now, you see 600 studies that have actually documented that there are differences in care based on the race and ethnicity of the patients that are receiving care. So if you look across a wide range of healthcare settings like managed care, public and private hospitals, teaching and community hospitals, all types of different disease areas and types of clinical services, we see disparities pretty much everywhere we look. And even after we've controlled for the various confounders like socioeconomic status, insurance status, severity of illness like the stage of presentation and comorbidities, etc., we still see these disparities in care. So people have a reason to be mistrustful. They experience disparities themselves, and there's literature backing that out itself. So what are we to do? We see disparities in all of these different types of services and many more: mammographies, amputations, influenza vaccination, mental health services, etc. And what can we do about it as healthcare professionals? And that's where I think the skills of cultural competency really come into play. But before we get to the skills, we need to start with some fundamental principles, I think. What I consider the fundamental principles of cross-cultural care, really of any care, but especially across cultures, is empathy, curiosity, and respect. Having empathy for patients even when they may be completely different from us. How do you have empathy for a patient who you can't speak with because of a language barrier, who you can't see because they're wearing a burqa, let's say? How is it possible? It is possible, and I think that's the root of this. How can we get beyond our own fears of the unknown and try to see people as people anyway? So empathy is crucial, and we'll talk more about that. Curiosity is part of this as well, because if we're not curious, we're not going to explore what's different and what's similar about people and how they see health and illness in again, similar and different ways than we might. So we have to be curious about their perspectives and not just assume that what we say is the right way to do things and that we just need to convince them. And then respect. So respecting their traditions, respecting their beliefs. True respect, not just token respect, but actually respecting that there are reasons and valid ones for why people do the things they do and believe the things that they believe. So again, we'll get into these in more detail with some little mini vignettes as we go forward. So this slide kind of shows that when you look across cultures, you see that communication is more challenging. So for white patients, 16% in one poll said that they had one or more communication problems with their physician, whereas 23% of African Americans and 33% of Hispanics and 27% of Asian Americans said the same thing, that they had one or more communication problems. So already we're at a disadvantage when we're working across cultures because we're seeing the challenges to communication, and we know that communication helps with empathic and better high-quality care. And when we don't communicate effectively across cultures, that's what leads to disparities. So for example, patients misunderstand their medications because of lack of communication, or their tests and procedures, which may lead to increased complication rates. And these are all backed by studies. They have poor control of their chronic illnesses when there's poor communication with their healthcare professionals, less preventive care, unnecessary tests and procedures, increased use of emergency departments for care, poor understanding of discharge instructions, and increased readmission. So really the things which, from the standpoint of utilization and from the standpoint of healthcare systems, are so important for the effective, high quality functioning of our healthcare systems, all are affected by poor cross-cultural communication. So this is the model that we've proposed, and again, as I mentioned, we've sort of worked on this and tweaked this over time. This is not the sort of the be-all and the end-all and the only thing that has to do with cultural competency in the world. This is just one approach to thinking about the types of issues that tend to come up across cultures. Now, again, I mentioned that knowledge about cultural groups is important, but it's not the main factor, because when you think about it, these issues come up across cultures no matter what the background is. So looking at something like specific customs. Everyone's got different customs about what they do related to health. Styles of communication may be different depending on what the patient's background is. Decision-making, ways of making decisions about medical issues are different. So all of the what we consider the core cross-cultural issues span cultural groups. They're not things which are just uniquely focused on specific cultural groups. Exploring illness and treatment beliefs is something that's important for all groups, including people that are exactly like you. Specific illness treatment beliefs, complementary alternative practices, personal meaning of the illness. And then there's the practical things like language and literacy. How do we actually communicate, with a patient, with an interpreter, working closely with an interpreter, thinking about the literacy level of the patient and trying to figure out how to reach the patient in the context of that literacy level. Determining the social context, sometimes those social factors are more important even than the cultural beliefs, and we'll talk more about those. And finally, engaging in a process of negotiation. So with that, I'd like to just kind of take a moment to talk about some of these things and give you some specific examples. So core cross-cultural issues. Let's take styles of communication as a really interesting example. So different people from different backgrounds may have different ways of communicating or different styles of communicating. There are patients that are much more deferent in their style of communication and patients that are much more assertive in their style of communication. They may be more direct about expressing pain or more reserved and more stoic about expressing pain. These are culturally based. And again, you can't pin it necessarily to a particular culture, but they are very culturally based. So as an example, a 56-year-old Cantonese-speaking woman is diagnosed with hypertension and is started on a medication. And she comes in after being started on the medication the previous visit and saying that she agreed to take the medication, and her blood pressure is still very, very high. And she works with the physician through an interpreter, and in discussing this, it becomes clear that she has not been taking the medications. And yet at first she's unwilling to really say that she's not taking the medications. Why is that? Very likely, this particular patient has a reserved or a deferent style of communication, does not feel that it's her role to tell a physician that she doesn't agree with what the physician said for her to do. And that's common in many, many cultural groups, and not necessarily cultural groups, but just across cultures. People may be reserved and reticent to tell a physician or a healthcare professional of any type that they do not agree with what the person is telling, what the clinician is telling them. So that's a style of communication issue. What do you do in a circumstance like that? Very important to try to understand the patient's style of communication. And when a patient is deferent like that, to little by little begin to build the trust and to begin to set the expectation that it's okay to disagree. Normalizing statements are a really good way of doing that. So for example, saying, a lot of my patients have trouble with these medications. They can be very, difficult to take for different reasons. And I'd love to learn more about what some of the reasons are that make it difficult for you. And those types of ways of communicating can open up a conversation that might have been sort of closed off before. Other examples of types of core cross-cultural issues that come up, mistrust. So mistrust is a major factor, again, for anyone, but for some patients, there are a lot of historic reasons behind it. So if you think about the African American community and history of discrimination and slavery in this country and segregation in hospitals and everything else that people have had to go through, which is, still exists in some ways, there's mistrust automatically that is, potentially built into these interactions. So if you, for example, a 76-year-old African-American woman who has vascular disease and a toe that needs to be amputated, she's in the hospital, she's doing poorly, it looks like the toe is gangrenous, and she says, she doesn't want to have the surgery done. She doesn't want the toe removed, even though from a medical perspective, it's clear that it's dangerous not to take this toe off. She might get septic, she might get worse, she might get very, very sick. But she says, first they take your toe and then they take your whole foot. What does she mean by that? They take your toe and then they take your whole foot. Well, she's concerned that she's seen a history of increased use of amputations among African Americans, which is backed by the literature. There's in fact disparities in the rate of amputations for vascular disease and diabetes for African Americans. And so this is something that she's experienced. Whether or not the actual data backs it up, her experience is extremely important. And what do we do? How do we build trust with that patient? Well, certainly having a primary care physician that's built trust over time and can actually work to explain the situation to the patient, can take time out from their busy day to spend 15 minutes just going through the reasons and the rationale, as opposed to, for example, a resident surgeon who doesn't know the patient at all and who comes in with a checklist and has the patient signing informed consent without really knowing what it is that they're getting into. So these are, and again, this is not to in any way take sides with surgery versus medicine or versus anyone else, primary care, but just to say that we all have to think about how to establish relationships with our patients if we're going to try to build trust with them. Little things go a long way for building trust as well. So calling people at home, giving them a lab result that they might have been waiting for at home instead of waiting for them to come back to their visit. Asking people about mistrust, actually consciously recognizing the mistrust that might be there and saying, it sounds like you're a little bit skeptical about the medical system and about how you might be treated. Let's talk about that a little bit. Can you tell me a little bit about your experience? I'd like to try to do better for you, and I know that I've been on your side for 5 years now, that I've taken care of you, or whatever it may be. Really having a frank conversation with people about that. That's worked for me. I think that's worked for a lot of my colleagues, and I'm really personally fascinated with the concept of mistrust and trust building and how it works in the clinical setting. There's lots of traditions and customs that come up. I'll give you an example of a 46-year-old Iraqi man who's Muslim and has diabetes. He's been on insulin, comes to the emergency department with severe hypoglycemia. What could have happened? Turns out it's the month of Ramadan, and there was no real discussion about what that meant, that he was actually fasting during the daytime hours and not eating his usual meals and not on his usual pattern. Didn't recognize that the insulin was so short acting in the way it was, and realized and didn't change his insulin regimen at all, and wound up getting very hypoglycemic because of low level of glucose that he took in, or low level he didn't take in many calories, and at the same time was taking the insulin. So an example of something that could have been prevented if there was a discussion on, tell me a little bit about your traditions that might affect your healthcare. Tell me about your diet. Are there any customs in your culture and your religion that might impact your care in some way? And that might have led to a good discussion about that. So there are lots of other examples around autonomy and decision making, and family styles of decision making versus individual styles, or key decision makers who are making decisions for a family member, and sometimes even alienating the medical team because they are saying that they want to take control of all the decisions and not tell the family member that they have a terminal illness like cancer, for example. Sexual and gender issues are very sensitive across cultures sometimes, and can be challenging to deal with. So those are just some examples of the core cross-cultural issues. In addition to that, just move forward here. There's, of course, language and literacy, and I'm not going to spend a whole lot of time on this because I think this is a whole subject in and of itself that we could spend an hour on. But how do we effectively know when to work with qualified interpreters and then work with them effectively? First of all, using family members as interpreters is really, truly a last resort. People have a tendency to rely on a family member and think that it's just fine. Patients tend to like it because they feel that they trust their family member, but family members are not trained in medical interpretation. They don't know the jargon, the terminology. They don't know how to actually interpret. So when to stop, when to pause, how to make things clear for people, when to recognize that something isn't being understood. And they can actually sometimes add their own biases in, withholding information or saying things in a way that's somewhat different than the doctor said. So it's very important to work with qualified, certified interpreters. Some guidelines for how to effectively work with an interpreter are clear, concise language, so keeping things focused, trying to keep your sentences short, pausing frequently to allow for the communication, not having run-on sentences and lots of ideas being expressed at the same time. Checking for meaning, so asking a patient to tell you back what they understood. That's a really great way to check that the patient understands. And actually allowing the interpreter to do more than just interpret. Very, very important to think about what an interpreter can do to help to overcome some of the cultural barriers, to understand some of the cultural nuances that might be going on. This is a controversial topic now, but it's really beginning to take hold in the field of interpreting that that interpreters do have a role beyond just the language. Don't assume that patients are literate. So there's lots of clues that a patient might not be able to read well. Have other options available for patients, so video, pictorial diagrams. Patient educators are great in that context. So this is kind of a whole separate topic again, but one that comes up oftentimes, both in cross-cultural interactions and not. So exploring illness and treatment beliefs. This is a huge, important topic. This is actually, in my way of looking at it, one of the core kind of underpinnings of cross-cultural care, and the thing that Arthur Kleinman really discovered for us in a way, brought into medical care from the field of medical anthropology many years ago now, the idea that patients have different conceptualizations of their illness, and that they run a spectrum between the biomedical and the non-biomedical. So common sense beliefs, things like I have diabetes, but it's in good control because I don't eat sugar. That's a very common sense way of looking at it. It's understandable why someone would think that. Lots of common sense things like that. So, I have high blood pressure, and my blood pressure goes up when I'm stressed. So in order to control my blood pressure, what I do is I just try to relax and not be stressed. And if I could do that, I know that I don't need to take my medication. So things like that, common sense beliefs that really impact care. Folk beliefs that are common and shared among a group about illnesses and treatments. Medical knowledge, so understanding a certain amount of the medical knowledge, but perhaps not fully understanding the medical knowledge, and using that in a way that sometimes can be challenging for providers, especially when the patients feel that they know more than the provider knows and have more information from the internet and whatnot. Personal meaning. This is one that I really find to be particularly relevant. So, a patient comes in with headaches, and you start to ask them, tell me a little bit about, your headaches and what's going on, and they seem really horrible. Bad headaches every day, and then you wind up asking them, why they think that they started when they did, and they tell you that in fact, their family member was recently diagnosed with a brain tumor. And so now they've got headaches and they're afraid that they could have a brain tumor as well. So things like that come up all the time. Again, this is not just cross-cultural, but in the cross-cultural context, it seems to happen even more often in some ways. So here are the types of questions that you can ask that can really help to explore these issues. What do you think has caused your problem? How do you understand it? Why do you think it started when it did? How does it affect you? What worries you most? How severe do you think it is? How long do you think it'll last? What kinds of treatment do you think would work? What results are you hoping for? These are all types of questions. You don't have to ask all these questions. I don't think I've ever asked all of these questions in one sitting, but I pick and choose, and I try to get my patients talking. And sometimes I modify them, sometimes I ask things in a different way, but I just really want to hear what the patient thinks. I sometimes will tell patients that the reason I want to do this is because they know more about their own bodies than I do in many ways. And some of the reflections or the thoughts that they have about what's going on can really help me to understand what's going on as well. So here's another polling question, and I'll turn it over again to Lynn to ask this one.
Great, thank you, Alex. So our final polling question should be coming up on your screen, and the question reads, how frequently do you explore your patient's explanatory models of illness? never, occasionally, often, or always. So if you could pick one of their choices, never, occasionally, often, or always, how frequently do you explore your patient's explanatory models of illness? And we'll give a few more seconds for folks to reply. It'll be interesting have a second question following. How often have you been asked these questions? But how often do you, as clinical caregivers, ask these questions? Okay, one more, two more, three more responses, and I think we can close the poll. Okay, so the answers come back from our participants. 1% say never, 44% occasionally, 39% often, and 16% always. Does that match what your expectations are, Alex?
Yeah, I think that about matches what my expectations are. I think that, we all have a tendency to want to do more than we do in the clinical setting. We're limited by time. We're limited, by having the patient that's waiting in the hallway, and so we don't necessarily get to the things that we want to get to. But I think that this data, to me, shows that folks want to do this, and occasionally are doing it or often are doing it. And my recommendation would be pick and choose good times to do it, and try to do it as often as you can, even if it's just one question. It'll really help to establish a relationship. It'll help to give you good information. It'll help you with diagnoses, help you with management, behavior change, etc. So that's interesting.
Great. Thank you.
Sure. Well, I'm going to go on to the social context now. And the social context, as I mentioned before, is an interesting one. There's so much the discussion now of the social determinants of health, and how social determinants have oftentimes a bigger impact on our health than medical care does. But what can we really do about the social determinants of health? And when you think about the cross-cultural perspective, there's particular aspects of social determinants that are very relevant. So the immigration experience, where is a patient from? So I typically will directly ask people about their immigration experience, where they're from, why they came to this country, how things have changed for them, how life has been different. And that'll often open up a really interesting conversation, not only helping to establish a bond and a relationship between us, because I'm curious about their background and why, what makes them the people that they are, but also really useful information sometimes. I just had a patient actually that I was working with a medical student who was having lots of vomiting and weight loss, and she was from mainland China and had been here for 4 years. And so we started talking about her immigration experience, and I thought maybe this was related to just feeling very, very upset about, kind of the move and the change in her life and coming to this country and not feeling comfortable here, and that she might be anxious and stressed about this. Well, it turns out, as we started asking those questions, that there was a different change that had happened that made her anxious and stressed and was vomiting and losing weight, which was that she had just changed jobs. And when we found out that her job had shifted because of her immigration history, and she was worried that she would have to go back to China, that's why she was so stressed and nervous, and that was why she's actually having all these GI symptoms. So that's another interesting example. Financial issues come up all the time, where patients can't afford their medications, can't afford their co-payments, and may be very shy or not comfortable talking about those issues. So having an open mind to these types of things and a very compassionate approach to saying, I know it can be very difficult for patients to afford some of these medications, and you're on several of them, so I'd really like to understand if this has been a financial challenge for you, or if you've had difficulty affording them. Really helps to, again, show that your solidarity with the patient, and that you'll try to find a way to help them even through those challenging situations. We talked a little about literacy already. Social stressors and support networks that patients have to deal with them, especially for immigrants that come from another country and don't have anyone here, or have very few people here that can kind of help them provide that social network that they're used to. So the final piece to this puzzle, or this model, is the clinician-patient negotiation approach, which ultimately, I think, if you think about interactions between healthcare professionals, and I've put physician up here, but this applies to any clinician. It's a negotiation between two different perspectives. They may be very different, or they may be just a little bit different, but there are always some difference between the clinician's perspective or agenda and the patient's perspective or agenda. But ultimately, we have to figure out as practitioners, how are we going to bring these things together to come up with a mutual understanding? We are not right, they're not right. Patients and physicians and nurses and others have to work together to kind of come up with these middle grounds. And I think that's really, in my way of looking at what cross-cultural communication is all about. It's about understanding a person in the context of their very, very complex cultural perspectives and backgrounds and ways of looking at the world, but as an individual, not as just a member of a cultural group, but as an individual, and using your knowledge of the person as an individual to really come up with this mutual understanding, which ultimately leads to improved cooperation on both sides between the clinician and the provider, clinician and the patient. And I wanted to just take it back to the systems level again, because not only do we have to be better in our own ways of interacting with patients, but I think that we have a real challenge here to try to work with our own healthcare systems, which are truly in need of overhaul around these issues. With all that's happened with healthcare reform, we both have incentives now to do this better, but at the same time, we have a shift of our focus on other things. So we've got new medical record systems coming in. We've got, quality goals to meet. We've got all kinds of things that we're tracking and following, and sometimes just this human touch of being a culturally aware, sensitive, and humble professional gets kind of shoved by the wayside. And I think this is the time when we have to set up systems that will make it easier and more effective for us to do this. And that might mean relying sometimes on team members. So relying on, our nurses, a physician relying on nurses, nurses relying on educators, educators, relying on the folks that are checking the patients in and getting information. So by working as a team, I think we can actually set up culturally competent patient-centered teams that are really able to do this better. And I'd love to work more on this, and I'm planning to work more on how to do that in healthcare as we move forward. So to close, I'd just like to say that I think that cultural competency is essential to high-quality, compassionate healthcare. It's not separate from quality; it is part of quality. Avoiding generalizations and assumptions is essential to also providing compassionate care, and thinking about the skills that we need to build so that we're not just relying on a set of kind of basic knowledge, but in fact, with every patient that we see, we're learning and we're connecting and we're trying to provide compassionate care. Ultimately, I think we need to meet people or patients where they are, but we need to find out where that is first. So with that, I will close and we will take questions. And I thank you so much for your participation in this webinar today.
Well, thank you, Alex, very, very much. And I just want to ask a quick question. I know that we have questions to respond to from the listeners, but I'm just thinking about how complicated so many of these interactions really are. And they take time. And, to your point of having a compassionate healthcare system, I'm just wondering how you manage to factor in the time needed. You can disperse some of the tasks across your team, but how can we make allowances for the complexity of some of the patients who might have not only complex medical conditions, but also complex social and psychosocial issues to address as well?
Yeah, it's a great question. I mean, it's the thing that we're all wrestling with, I think, in this field and in healthcare in general, is this notion that, we're asking people to do more, and they don't necessarily have more time or resources or anything else. So how do we make it possible to make this work? And I think, hopefully in an era of paying for value rather than paying for visits, for example, we will be able to come up with ways of keeping people healthy, and that will be a valuable part of what we do, and that might not just be us spending time, but it might be referring to other people on the team to spend time, quality time with people, to get to know them and to understand their perspectives. Ultimately, if we can keep people healthier, you would think that that would be a goal that would be valued in the system. And
Right.
you know, we're seeing movements towards doing that with the Medicare demonstration projects, and you know, with complex patients and you know, dual eligible patients who are complicated. And I think for these cross-cultural types of situations, it's also similarly complex.
Yeah, for sure, for sure. Well, let me ask Lynn to hand over some of the questions that we've received from our listeners.
Excellent. And we have a number of questions, and we only have a few minutes, so I'm just going to jump right in. How do you collaborate with chaplains about the spiritual care needs of your patients and families? One example might be a patient family refusing removal of a vent because of belief in miracle healing. So there's been a couple questions about how do you interact with chaplaincy.
I think just in the way that you said, you know, involving them in situations like that from the beginning, early on, before it gets to a crisis situation, I think is very important. Allowing the chaplains to build a relationship with the families and with the patients, so that they also are part of the trust-building team. And also, honestly, believing that the chaplains have an important role. I think the healthcare, the clinicians particularly, need to trust that the chaplains can have a really important role. We've had some really good experiences with some of the chaplains that we've worked with at Mass General Hospital who have really helped to, in a way, solve cases, you know, really helped to understand what was going on, what was the challenge, what was the problem, and have allowed people to either allow the patient to kind of understand why something was important for them from a medical perspective, or allowed the healthcare team to understand why they didn't necessarily have to push a particular, you know, procedure, surgery, or something on a patient who had very strong reasons for not wanting it.
Excellent, thank you. Let's see. How do you cope with different cultural views on pain management?
Well, we're learning more and more about pain management and how there are, you know, real disparities in the management of pain across cultures. And I don't, as of yet, I think that we don't have great answers on how to approach that situation, except to say that we need to treat every person as an individual. And really, in this context of pain management, mindful practice is the key, because if you're making assumptions in any way about a person based on things which are not clear-cut, you know, facts, you will have a tendency to either undertreat or overtreat patients with pain medications. And so, getting to know patients, understanding, you know, why they feel they need pain medication, understanding the nuances of expression of pain. So it's not just how much pain someone may be feeling, but it may be also in the way they're expressing the pain, and thinking of other options. I mean, I think there's been a movement away from masking pain with opiate, you know, medications, because we've realized that we've probably gone to the other side. We've swung to the other side of the pendulum on that aspect of care. But yet we still need to figure out how to treat people's pain. So it's a complex question. I don't have a great answer for that.
Well, you do, but because you're saying go back and talk to the patients and understand them. That's wonderful. Right. Let's see. Could you share your ideas about cross-cultural beliefs about death and end of life, and how you approach this in your practice?
Yeah. So that death and end of life care is a big one. I sort of tend to cover that when I'm teaching about this in the decision-making, you know, family dynamic type of section in our model, but it really is a separate thing in a way. You know, obviously, death and dying has become such a huge, important issue as we realize how much healthcare resources we're spending to try to keep people alive at the end of life without understanding what their real needs and perspectives are. There is a tendency among many minority groups and non-minority groups as well, but especially minority groups, to not necessarily trust that the healthcare team has their best intentions in mind. And so at the end of life, if people talk about withholding care, withdrawing care, or withdrawing, treatment, let's say, and comfort care, that might be perceived as giving up on a person unduly. And so from that context, building trust from the beginning and trying to understand a patient's wishes before they get to that point, I think is probably the key.
Excellent. Thank you. I'm afraid we're running out of time. I'd just like to again thank Dr. Green for sharing his expertise and insights with us, as well as everyone in the audience for setting aside time in your busy day to participate. We hope that you'll join us for upcoming programs in the Compassion in Action webinar series, including When Emotions Fill the Room, How to Use Empathic Statements to Move a Conversation Forward with Dr. Catherine Aragon on July 19th. Please visit our website to learn more about the Schwartz Center for Compassionate Healthcare and our membership program, and please save the date, October 28th and 29th, for our Harvard Medical School Continuing Education course, Compassion in Practice, Achieving Better Outcomes by Maximizing Communication, Relationships, and Resilience. And Alex Green is going to be one of our workshop leaders. We know you're busy, but we'd very much appreciate your taking a moment to complete the electronic survey upon exiting today's program, as we value your input. Thank you and have a great day, and thank you, Beth. Thank you, Alex. Have a great day, everybody.